welcome to this important event. It's terrific to see many of you here today. My name's Justin Coonan. I'm joining you from Sydney, Australia, where I'm on Gadigal land and want to acknowledge the traditional owners of the land I'm standing on. This is traditional in my country, Australia. I should also say greetings from tomorrow, as the clock has just struck midnight. But gender equality is extremely important, and the fight continues at midnight. I'm here because I'm co-chair of UHC 2030, the international multi-stakeholder movement for universal health coverage. Before I keep going, if you would like to listen to me in French, please click the interpretation globe at the bottom of the screen. We do have interpretation for you. So as I said, I'm from UHC 2030, and we work with a broad range of diverse partners, including those partners in today's event, to accelerate sustainable progress towards universal health coverage, with a focus in particular on building equitable and resilient health systems that leave no one behind. One of our key roles has been to prepare, if you like, consolidated inputs from the UHC movement for the UN high-level meetings on universal health coverage, which have taken place at the UN General Assembly in 2019 and 2023. And we call these inputs the action agenda from the UHC movement. We launched them before the UN General Assembly high-level meeting on UHC last year. And this action agenda calls on political leaders to take concrete actions on their commitments to achieve UHC through 8 key asks or action areas. And it's one of those I want to highlight, action area 7, which is to guarantee gender equality in health. That ask is there because in 2019, UHC advocates led by Women in Global Health demanded it. Rupa Dutt, Executive Director of Women in Global Health, I know you're on this call. It was you on the floor of the UN General Assembly multi-stakeholder hearing that spoke up. And we're really grateful that you and Women in Global Health did that, and that you demanded that gender equality become one of these key asks. So this is your agenda. And it's really critical that that ask for gender equality is there. In turn, during the high-level meetings, both in 2019 and 2023, member states recognized in the political declarations from those high-level meetings that gender equality is critical for UHC. And in reverse, that UHC in turn will empower women and girls and strengthen gender equality, development, economies, and contribute to peaceful and inclusive societies. But we all know that political commitments made in New York are one thing, and the reality on the ground in countries is another thing entirely. Since the COVID-19 pandemic, which has widened pre-existing inequality gaps, including on gender, and which has reversed progress on sustainable development, it's now estimated by UN Women and the UN Department of Economic and Social Affairs that it will take the world 286 years to close the gaps in legal protection and to remove discriminatory laws relating to gender. UHC 2030 produces what we call the State of the UHC Commitment Review, and that data shows that UHC processes in country are still gender blind, and that there continues to be a lack of commitment to increase women's representation in health and political leadership. So we have a mountain to climb in order to translate those aspirations for gender equality into reality. And in order to accelerate the progress towards gender equality and UHC 2030 is collaborating with the Alliance for Gender Equality and UHC and with the Partnership for Maternal, Newborn and Child Health to advocate for implementing a gender-responsive approach in health system strengthening to achieve UHC. And that's why we're here today. So on behalf of UHC 2030, on behalf of the Alliance for Gender Equality and UHC, and on behalf of PMNCH, I'm really pleased that you've all joined us today for this important discussion, which takes place, as we know, on the sidelines of the Commission on the Status of Women taking place at the UN in New York. Some housekeeping before we begin this discussion. As I said a few minutes ago, please introduce yourself in the chat and please post any feedback on the discussion. We're keen to learn about your perspectives and your good practices and to strengthen collaboration and solidarity among all of us who are working to support the establishment and progress on gender-responsive health systems. So please make yourself at home. Please feel welcome wherever you are in the world. Please use the chat. We'll take a record of that chat. As I mentioned before, we have French interpretation available on this webinar. Click the symbol at the bottom to access it, the globe symbol. So before we have a discussion with an amazing group of panelists and we have a terrific keynote, we're going to start with a presentation. And I now have the pleasure to invite Ms. Farheen Navi, Policy Associate at Women in Global Health, to present key messages on why countries need to take a gender-responsive approach in health system strengthening to achieve universal health coverage. Farheen, over to you.
Thank you, Dr. Conan. I will just share my screen now. I hope it's visible for everyone.
Yeah, looks good.
Thank you. Good morning, good afternoon, good evening, everyone. I am speaking today from Women in Global Health, which is one of the co-conveners of the Alliance for Gender Equality and UHC, an alliance of over 100 civil society organizations who have campaigned together since 2019 for gender-responsive UHC. In the last year, we have been working with partners to draft an advocacy brief to explain what we mean by gender-responsive UHC and outline why health systems must be gender-responsive to address the health needs of all users and not leave anybody behind. In September 2023, during the General Assembly, member states met at the second high-level meeting on UHC and reaffirmed the commitment they made to achieve UHC by the target date of 2030. But in the same year, the WHO concluded that the world is off track to achieve UHC by the target date, and the pandemic has taken us backwards. 4.5 billion people are still not covered for essential health services, and around 2 billion people are facing financial hardship due to health expenses. The primary healthcare-driven UHC intervention can save millions of lives. But looking at these statistics here, it is clear that there are significant differences in health risks, disease prevalence, and outcomes between women and men that cannot be explained by differences in physiology and biological sex alone. The answer lies in gender differences. Gender is a critical determinant of health. Gender inequalities affect health outcomes as well as access to services. Gender norms, roles, and differentials in power relations and control over resources contribute to differences in vulnerabilities and susceptibility to illness, health behaviors, uptake of services, and health outcomes. There are a multitude of examples that show the impact of the gender inequalities. Women and adolescent girls all over the world are dying from preventable causes during pregnancy, childbirth, and unsafe abortions, and from lack of autonomy to make their own health decisions. 225 million women worldwide do not have access to contraception, which, if provided, would prevent 52 million unintended pregnancies each year. Every year, around 3 million girls aged 15 to 19 undergo unsafe abortions. And we must also acknowledge the impact on men. For instance, men in every country in the world have lower life expectancy than women. Yet, despite the evidence, as Dr. Conan mentioned before, UHC 2030's latest State of the UHC Commitment Review shows that UHC processes are still gender blind, and there continues to be a lack of commitment to increase women's representation in health and political leadership, which would enable better women's professional expertise in health and perspectives to be heard. While women constitute 67% of the global health and care workforce and are powerful providers of health services, many are in roles accorded lower status and pay, or no pay at all, and they hold only 25% senior decision-making roles in the health sector. So UHC is central to achieving Sustainable Development Goal 3, which is good health and well-being, and embodies a transformative force for the entire 2030 agenda. In 2015, member states committed to achieving UHC as part of their pledge to SDG 3. This commitment was reaffirmed in the 2019 political declaration UHC as well. But in the 4 years since the 2019 declaration, the context for UHC has changed dramatically. As Dr. Konen noted earlier, the COVID-19 pandemic widened pre-existing inequality gaps, including gender inequality, and reversed progress on sustainable development. Following, in September 2023, political leaders reaffirmed their commitment to achieving UHC by the target date of 2030, UHC that is gender, race, and age responsive. Member states recognize that gender equality is critical for UHC and will in turn empower women and girls, strengthen gender equality, and inclusive societies. A gender-responsive approach to UHC is essential to inclusion and leaving no one behind. I want to end this presentation with 8 key messages to member states for implementing a gender-responsive approach in health system strengthening to achieve UHC. These key messages emphasize that, first, gender is a critical determinant of health. Gender inequalities affect health access and outcomes. UHC, health system strengthening efforts must be gender responsive and equitable. Second, health system strengthening based on primary healthcare approach is the most efficient and sustainable way to reach UHC. With gender being one of the major contributors to health inequities, a PHC approach includes ensuring that factors within health systems and some that originate outside the health system contribute to gender-related health inequalities are addressed. Our third message is that health systems must be informed by sex disaggregated and gender disaggregated data and address gender inequality in the health and care workforce and in political leadership. Fourth, that to be gender responsive, health systems must consider the wider social and economic implications of gender inequalities and include equitable access to health services without causing financial hardship. Women on average earn less than men and own fewer assets. So this is a critical point for gender equality. Further, beyond sex and gender, the health system must consider which groups in society may suffer multiple disadvantages due to their race, caste, ability, sexual orientation, age, or gender identity. Taking such an intersectional approach will enable more effective targeting of resources. Sixth, as I have noted earlier, that health systems must ensure that women and girls are equally represented in health and political leadership. Women and girls are best placed to articulate their own needs and define how these can be met across their life course. My seventh point is that all health systems must ensure that no one faces barriers to access or stigma when accessing care, including sexual and reproductive health care. Depending on the context, social groups may be stigmatized and deterred from seeking healthcare due to the work they do, sexual orientation, their gender identity, poverty, and many more factors that stand in the way of universal health coverage. In particular, women and adolescents must have access to health services that allow them to realize their sexual and reproductive health rights and bodily autonomy. ASRH services must be incorporated into essential UHC benefits package. Finally, safe, decent, and equal work for women health workers and care workers must be guaranteed via gender-responsive policies to attract, protect, and retain women in the health and care workforce, which will in turn help address chronic health worker shortages and build equitable and resilient health systems for UHC. To conclude, UHC is only universal when it reaches everyone, everywhere, including the most vulnerable and marginalized. The integration of a gender lens into all aspects of health systems, including the governance, design, financing, and delivery of health systems, is needed to achieve universal health coverage and deliver health for all by addressing inequities. Gender-responsive health system addresses the health risks and needs of all individuals, including women, men, girls, boys, and other marginalized groups. Thank you.
Thanks very much, Farheen, for that tremendously rich background, which I'm sure will inform an equally rich discussion with our panelists today. So that was a terrific start. Before that discussion, I'm now honored and we are very excited to have with us Dr. Catherine Vidal from France to deliver today's keynote. Dr. Vidal will present the conclusions from the 2020 French High Council for Gender Equality report entitled Taking Sex and Gender into Account for Better Health Services, a Public Health Issue. Dr. Vidal is a neurobiologist, honorary director of research at the Institut Pasteur in Paris, a member of the High Council for Gender Equality, as well as a member of the Ethics Committee of the National Institute of Health and Medical Research. Extremely distinguished career, and as I said, we are delighted to have you here with us, Dr. Vidal. Over to you.
Thank you very much for your invitation. For me also, it's a great honor and a great pleasure to introduce the debate. So I will share the screen. Tell me if it works or not. Is it okay?
Ça marche.
It's okay for you?
Yeah.
Okay, very good. So I will present the main points of my report commissioned by the High Council for Equality of France, which is entitled Taking Sex and Gender into Account for Better Care, a Public Health Issue. And sorry, I will switch now to French.
So this report starts from the persistence of the social inequalities in health between men and women that lead to discrimination in health. So the importance of this issue led many people and many countries to think about gender and health in the institution of health and in the policies of public health. And so in this field, France is not advanced. And so it is important to show how the issue sex, it is innovation in medicine, so the research and the health policy. So it is important to make a distinction between the notions of differences and inequalities. And so the differences are hidden to related to gender, hormone, and so the inequalities are related to social, cultural, and economic factors. And so gender is very important. So we have the social representatives related to gender influence the attitudes of patients and those who have the care, the patients. So also this leads to degradation of the style of living and sexual aggression, violence. And so that is why in this process of integration between biological sex and environment, which is the source of health inequalities, so it is important to have medical vigilance, surveillance to ensure equal conditions within the access of care. So we'll see now some examples. The importance of the biochar is not well diagnosed. So it is seen as a disease from women, from men. So, and women also have more chance that this is due to emotional reasons and not cardiac health or heart problems. So we have in some case of hospitalization, let's say in case of infarction, they minimize the symptoms, and so they call the urgent systems later. So this is an illustration of the importance of the social rules and the stereotypes related to the gender that will influence the activities of patients. And so another example, depression, which is seen as a feminine disease. We have brought the idea of change, of humor, menstruation, but actually there is no scientific demonstration of the role of hormones within depression as compared to other factors, let's say cultural environment. And so this is very important. So we had some international studies which have been carried out in 200 countries that show that the more the social economical level is high, there is a gap between women and men within in the cases of depression. So we have more depression by women because they are exposed to risks that led to depression. Another example, endometriosis, which is a disease that has been ignored, and so once one women over 10, it is a first cause of infertility. So we may see that endometriosis has been recognized by the medical staff as a organic pathology, so had to wait 20 years so as they should start some health treatments. So we have also this diseases which are caused also in women who have osteoporosis, but we have other problems as well because it is under diagnosed in men because it is seen as a feminine disease. Another important issue is the economical precarity. 70% of the poor workers are women, and 85% of monoparental families are related to women. So this is related to low quality, low salary, and so it leads to depression, etc. Another important issue, which is important, the professional risk and the hard work. So some cancers caused by the professions are under-evaluated by women, which is the case of lung cancer, and also normally we see that people working at night will have 26% of cancer. So we can see breast cancer. And so we have some psychosocial risks. Another important issue concerning this difficulty in work, this is underestimated, and it is hard to be recognized for women because the criteria of professional diseases are based on the male work. Another thing is the double work. So we have the also work at home and the problem of sexual aggressions and violence that lead to risks for the physical and mental health in women. So this report recommends, we have 4 recommendations to integrate the theme gender and health in the education, the formation of medical professions. First, the initial education and specific formation, and also have to have new institutions of research and medicine on the gender and health theme. It is important to assure the access to care in precarious situations, and also we have prevention campaigns as well, and to favor the access to responsibilities within the health and research. And to end, I would say that it is important to take into account the fact that the dimension of gender related to sex in the field of health has some implications in terms of scientific knowledge, treatment, medical treatment, and prevention and optimization of health costs. So this is major in order to build some policies in order to improve research and public health for the good of women and men. Thank you for your attention.
Thank you so much, Dr. Vidal. An incredibly rich report. And we all recognize the leading role that France has played in the movement towards gender equality, including through the Gender Equal Health and Care Workforce initiative led by the government of France, as well as Women in Global Health and WHO. So thank you for being here and for your contributions. Let's now turn to a really excellent panel. I'm going to introduce our panelists one by one as they speak. And our first is Dr. Wilhelmina Jalla, the former health minister of Liberia. Dr. Jalla served as the founder, CEO, and medical director at the Hope for Women International Medical Center, Liberia, until 2018. And during her tenure, the center provided health services to over 50,000 patients, including services to pregnant women, children, and men. Dr. Jalla served as acting head and educator for the obstetrics and gynecology department, as well as the director for the gynecological cancer program at the John F. Kennedy Memorial Hospital in Liberia. Dr. Jalla currently chairs the incident management system of Liberia on COVID-19, an incredible wealth of experience. I'm sure you'll agree. Dr. Jalla, welcome.
Thank you so much for allowing me to be on this panel. The subject that we are speaking about today is very, very important. In Liberia, the strategic plan for the government on sexual and gender-based violence during my tenure was set up as a multi-sectorial platform where we had the involvement of the Ministry of Health, Ministry of Education, Ministry of Gender, Ministry of Agriculture, the Ministry of Gender, Social Protection, and the Gender Ministry. Liberia has taken a lot of bold steps. One of the things that we had done with support from the partners, we were able to set up centers where we have police, health providers, justice ministries, psychologists to deal with sexual abuse and sexual-based violence against women. We're also able to set up a DNA center which we didn't have to help with the forensics for the women. We have also been able to abolish female genital mutilation in about 2 of our 15 counties, where we have empowered the zoos that were doing the FGM to be able to sustain themselves and cut off those harmful traditional practices. In order for us to put a gender mainstreaming on our agenda, the government have established gender inclusion units in all of the ministries of government, just to make sure that there's equity within the system. We are allowing women to report grievances and prevent any other sexual harassment, because we know how difficult it is for women in these spaces. For our youth and young people, we have comprehensive sexual education program that's ongoing for junior and senior high school students and those who are out of school, because we have a lot of other school youth, or we are advocating for more domestic resources to go to supporting our youth or within the system. We also have made a commitment to the FP 2030 towards improving the health and well-being of adolescents and young people, encouraging them to be at the table with us. Because if they are not advocating for themselves and telling you what they actually want to happen in their space, you will miss out on exactly what to do to improve youth and empower them. We have also put together a lot of training systems for our healthcare workers. Today, we have midwives that are or getting bachelor's degrees and even master's degrees. Before, this was not happening in our space. We have a lot of nurses that are trained in the family planning that have master's degree in public health, and they are helping with the family planning services. So our family planning have gone up. We have a little sticky issue on the abortion services because we want to change something in the old law that would make, or not to make abortion legal, but to make it safe for those who wanted to have those services done. So the law has not yet been passed, but we are working on it with other advocate groups to make sure that those services are passed. We also have a very good community health services because you need to reach out to the community in order to make sure the gender balance and equality exists within the system. So today we have a lot more community health workers that are female, the community supervisors that are female, and we are making sure that they are skilled, they are supplied, and the community health service. But the community workers, we are still discussing them being on payroll. So a lot have been done towards increasing the strategic plan toward ending sexual and gender-based violence and other things within the country, and making sure we have gender equity within our system here in Liberia. So we want to thank the past president for his work on passing this strategic plan, and we hope that the new government will continue on this same path to make sure that there's equity for women, girls, as well as boys. I want to thank you.
Thank you very much, Dr. Jala. Terrific to hear how much work has taken place in Liberia. And thank you for picking up on a number of themes around the role of community health workers, around the need to empower youth, around gender-based violence, because I think our other panelists will expand on each of these themes as we come. So a terrific start. Let's move to our second panelist, Mrs. Yvette Ouedraogo from Burkina Faso, who is a nurse and a midwife by training, as well as a specialist on gender equality and gender-based violence. She's worked within the UN system, in governmental and non-governmental roles in West Africa, and currently serves as gender-based violence specialist for the UNFPA Cameroon office. In 2023, she was selected for a Women in Global Health Heroine of Health Award, extremely well-deserved. So, Madame Ouedraogo, from your experience, how can UHC programs effectively address the health needs of women, girls, and marginalized communities with a specific focus on tackling gender-based violence and promoting sexual and reproductive health and rights?
Thank you, Dr. Justin, for the mic, and thank you to Women in Global Health Burkina Faso.
I think you're still muted. Can we arrange for this?
Is it okay now? you
our
hear
technical
me?
colleagues.
I think so. Thank you. I'm speaking on behalf of Women in Global Health chapter Burkina Faso. So let's move in French for all West African participants here. Merci beaucoup et je pense qu'à la suite des deux panélistes qui ont déjà
Thank
présenté
you so
la
much.
question
And
du
so
genre
the
et
issue
l'importance
of
de la
gender
pertinence du genre
has
en
shown
termes
the
de
importance
couverture
of
sanitaire
gender
universelle.
in the
Merci à
health
démontrer, mais
coverage.
là, c'est de savoir
But
comment,
it is
comment
important
ces programmes-là
how
peuvent être
those programs
genre
have
sensibles ou genre
been
spécifiques. C'est là la question.
gender
Et comme vous l'avez dit,
sensitive, and
le
also
genre a
as
une
you
influence
have
certaine
well
sur les
said,
questions de
gender is
santé, sur la décision.
major
Et ça va
in all the
au-delà
decisions of those
de l'aspect
problems. So
financier.
it
Quand on
goes
va de la
beyond
définition
the
de la couverture
financial
sanitaire qui vise
aspects,
essentiellement
because we
à
are
briser cette barrière
gearing to
financière à
stop
l'accès
this
aux soins,
financial
il faut
barrier. So
nécessairement
we have
considérer ces
to
questions
take
de genre
into
puisque les
account
normes
all
culturelles, les normes
the
sociales
norms and
ont une
social norms,
influence
because
certaine
they
sur
have
la santé de
very
quelqu'un,
important
sur les facteurs de risque. Et bien
importance in
sûr,
the
il
risk.
faut que ces
So
programmes de couverture sanitaire
this
universelle-là
coverage, health
des
coverage program
programmes qui vont
should be
lutter contre les
should
inégalités,
fight against
qui
the
vont promouvoir l'équité
inequalities that
santé.
will
Catherine l'a
bring
dit tout à l'heure,
equity in
l'équité en
terms of
santé
health.
est une
Catherine has
condition
said
sine
this
qua
is
non
a
pour
sine
une
qua non
effectivité de la
conditions
couverture
to
sanitaire
the
universelle. Il ne
efficacy
suffit pas de
of
dire,
the
par
health
exemple, que
coverage.
les soins,
It is not enough
que
to say
les
that
choses sont gratuites quand ce n'est pas la femme
the
qui a le
healthcare
dernier
is
mot, quand ce
for
n'est pas la
free,
femme qui
but
décide
because
quand consulter le
this is
service de
not
santé. Ce n'est pas
the decision
suffisant
of
de
women.
rendre
It's not
gratuit la
enough to
planification
make it
familiale quand ce n'est pas la femme
familiar
qui décide
planning.
toujours
This is
de
not
quand
enough
et
only
comment
to
et quelle
build
méthode utiliser. Donc, c'est
for
vraiment
free, but
travailler à
so we have
intégrer
to
le genre
work and
à tous
integrate
les
the
niveaux
gender in all levels.
de l'implémentation, de la
The
planification des
implementation
programmes de couverture
of
sanitaire,
the planning
depuis
of
l'analyse situationnelle,
universal
en passant
health
par
coverage,
l'élaboration des
and
politiques,
also the
en
elaboration
passant
of
par la mise en œuvre de
policies
ces
and the
programmes-là
implementation of those
jusqu'au suivi
problems.
à l'évaluation. Le genre doit être
Also,
intégré. Cela veut dire qu'il faut prendre en
so
compte
it
aussi les
means that we
priorités
have
de la
to counter
communauté. Il faut
to take
intégrer
into account the
des
community,
besoins
to
spécifiques,
integrate
puisque
the
les femmes et
specific needs,
les
because
hommes ont des besoins
women,
différents.
girls,
Et nous
men
savons
have
aussi que
different
la violence
needs.
basée sur le
So we
genre
know
aujourd'hui
that
reconnu comme un
today
problème de
this is
santé
recognized
publique
as the public
influence
health
énormément
issue, and this
les femmes,
influences
surtout en Afrique de l'Ouest.
women in
30% des
West
femmes sont
Africa as
victimes
well.
de
So
violences
women
physiques
are
ou
victims
sexuelles,
of sexual
selon
and
ce que
physical
l'OMS
violence.
a reporté. Et aussi,
And
comment
we have many
intégrer la
reports on that. So we have to
PMNCH
integrate
pour
the
prendre en compte les
community
normes
to take
sociales,
into
pour
account the
lutter contre
social
ces normes sociales
standards and
négatives-là.
to fight
L'homme
against
aussi
this.
est
And
un
so
partenaire
man
clé
also
qui
is
devrait
a key
intervenir, qui
partner.
devrait
He
être
should
plus engagé
intervene.
pour
He
le
will
respect des droits
be
sexuels et
engaged
reproductifs des
in
femmes,
order to
pour
achieve
la
the
lutte
right
contre les violences basées sur
of
le
women
genre.
and
C'est
men.
pour
And
cela que ces
also that is
programmes de
why
couverture
this
sanitaire universelle doivent
program
justement
should
travailler à
work on
utiliser
the
des approches telles que
using
la
approaches
masculinité
such as
positive
the
pour que les
positive
hommes soient
masculinity,
encore
so that
plus
men
sensibilisés et
are more
engagés à réduire ces
sensibilized and
violences basées
engaged
sur le
in order
genre-là.
to
Et
reduce
aussi,
violence, sexual
pour que
violence
personne
against
ne soit laissé
women,
de
and
côté.
so that
Voilà,
nobody
c'est
is left
universellement reconnu que
behind.
la
So
santé est un
it
droit
is recognized
fondamental.
that health
Et
is a
donc, ce
basic,
n'est pas parce que ce sont
major
des femmes qu'il faut le
condition.
permettre, simplement
So
parce que ce sont des
it's
êtres
not only
humains.
because
Et
they
quelles
are
que soient
women,
les
but
populations
because they
vulnérables
are
ou les populations
help,
marginalisées,
they
leurs
are
besoins
human
doivent aussi
people.
être
So it should
adressés de
be
façon spécifique.
addressed in a very
Que
specific
ces
way
personnes
so
n'ont
that
pas
those
les
people
moyens pour être
don't have the
affiliés à
means
une
to be
quelconque
affiliated to
assurance ou
any
un quelconque système
system
de
of
santé.
health
Donc,
or
c'est
any
vraiment
system of
aussi de respecter les exigences de
so we have
non-discrimination qui sont
some
universellement
demands
reconnues
or
pour que
insurances.
quelle que
So
soit son identité, quelles que soient ses
no matter the identity or
personnes soient
specificity of
reconnues.
those
Et
women,
je
so
ne
they should be taken
saurais
into account. So I
finir
should
sans
just
mentionner
like to take into account the importance of the social ecological model that allow us to see the different levels of health determinants and all these universal health coverage. Use this approach either in the individual level or the interpersonal level, if we take into account in the development of policies. And so that is why we should have some efficient programs that meet the needs of people and that don't leave people behind, because everyone has the right to have a good health program.
Over to you.
Also, thank you so much.
Thank you very much. That was again a really rich intervention. Thank you for highlighting that health systems need differentiated interventions. You can't, gender equality and equality in general doesn't mean you treat everyone the same. It means you treat different people according to their needs. And I think that's tremendously important to keep in mind. And also thank you for highlighting that when we talk about gender equality, it isn't women who have to carry the burden on their own. It's also the role of men to play their role too. Two extremely important points that we'll take forward. Let's turn now to WHO, of course, an important actor in these discussions. And our third panelist is Dr. Anna Coates, Senior Technical Lead for Gender at WHO. Dr. Coates has a long career as a gender specialist with various UN agencies, including the Economic and Social Commissions for Latin America and the Caribbean, and for the Asia Pacific, as well as with UN Women, and as Chief of the Office for Equity, Gender and Cultural Diversity at PAHO. She was Senior Gender Equality Advisor for the WHO Sexual and Reproductive Health Department before taking up her current post. Anna, if I could ask you what WHO's approach is to achieve gender equality through health system strengthening, and in particular in the context of progress towards UHC. Over to you.
Thank you, Justin, and thanks also to the previous panelists. I think many of the points that I make have also come out in one way or another through everything that has been already said. But what I would like to begin with and really emphasize is that universal health coverage is rooted in the principle of health as a human right, which means meeting everyone's unique health needs without discrimination. And it's therefore really essential for achieving gender equality. But to really achieve that potential, there are some key considerations to bear in mind, and that's what I want to just mention today. The first of those is that gender responsive health systems are ones that prioritize issues that have been deprioritized because of gender inequalities in power. Reproductive health and rights and violence against women, as we've so eloquently already heard, they really need to be prioritized, and they often do not receive the investments that they need. In addition to that, there are harmful gender norms that constitute risk factors across many different health domains, affecting women, gender diverse individuals, as well as men. For example, suicide deaths are higher amongst men, but women are disproportionately affected by harmful gender norms because of both gender inequalities and biological differences, and the fact that those are ill considered really in clinical research and in health policy. Mortality figures alone can often mask some of those inequalities. So, for example, attempts at suicide are more frequent amongst women. Gender and other forms of discrimination are key drivers of women's poor health. So, for example, gender norms affect diet and physical activity, leading to higher rates of obesity. They also expose women to infection and higher mortality due to unsafe water and sanitation. And different groups of women, girls, and gender diverse individuals face disproportionate health challenges. So, for example, women with disabilities, those who face discrimination based on sexual orientation or gender identity, Indigenous peoples and others. And this leads me really to what I would say is really the second priority, and that is that gender responsive systems are ones that make evidence-based decisions using sex disaggregated data and wider gender data. Evidence and understanding of sex and gender differences across the life course and in all health domains remains really inadequate. And during COVID, sex disaggregated data, for example, on testing, hospitalization and admissions to intensive care units were really rarely reported. WHO has recently adopted the Sex and Gender Equity in Research Guidelines that aim to bridge this gender evidence gap. Routinely collected data through health information systems also has really massive potential to improve gender responsiveness, especially by monitoring access to services and health outcomes. Thirdly, gender responsive systems are based upon inclusive governance and women's leadership. The voices of those who have been excluded from power, particularly women and gender diverse people, are really crucial. They are the experts in articulating the challenges they face and the solutions. Worldwide, we know, we've already heard that women are vastly underrepresented amongst those in senior level positions in the health sector, and this needs to improve. But leadership can also come in many forms, including through community and civil society voices. And gender responsive systems really need to actively seek out those voices to improve trust and health outcomes. And in WHO, we've had some great examples of how that's worked. So, for example, the maternal health of Indigenous women in the Americas was improved through knowledge dialogues. But gender responsive health systems are not just about focusing outwards. It also means walking the talk inside as well as out. Globally, as we've already heard, 67% of the paid health and care workforce are women. And underinvestment in this work can result in women shouldering even more unpaid health and care work. And this was really explored and in a really great WHO report that was launched here at CSW, where I am at the moment, on Fair Share for Health and Care. So there is a lot involved in gender responsive health systems, but what I really want to finish with is the fact that gender responsive health systems require a whole of system approach. There are some great WHO initiatives, great other initiatives that we've heard about today that support gender responsive health systems, but we all need to do more. We need to systematically identify the precise actions within all of the health system building blocks that we can bring together in a coherent gender responsive health system framework. That's really one of our aims at WHO, especially over the coming months, and we really do look forward to working with partners to take that work forward and to make a genuine difference. Thank you.
Thanks very much for that, Anne. Thank you for bringing us back to the real basics, which are that fundamentally UHC is about equity and fundamentally it's about a systems approach. I think both of those two things are key. We turn now to our final panelists. And of course, as we've heard, gender equality doesn't just mean gender equality for women. It means gender equality for everyone. And it's critically important that we hear also what that means for men as well. So our final panelist is Peter Baker, Director at the Global Action for Men's Health. Mr. Baker was Chief Executive of the Men's Health Forum in Great Britain, the Campaign Director of HPV Action, and also undertook a review of national men's health policy for the Irish government. So Peter, my question to you is, why should health systems be gender responsive, and how can they address the health needs of men and boys? Over to you.
Well, thank you very much, and thank you for inviting me to take part in this important discussion. I suppose if I have one key message, it's that when we talk about gender and health, we need to consider all genders, and I'm very pleased to be able to provide a perspective from a men's health organisation to hopefully highlight the relevance of thinking about men to this debate, because we know that men's health is poorer than women's in many important respects, not only life expectancy, of course, but also the outcomes of many serious diseases like cancer, cardiovascular disease, diabetes, suicide, and other issues. But having said that, I'm very conscious that we must at all costs avoid a competition between men and women in terms of trying to convince each other about who has the worst health. It's clear that in many respects, men's health is worse than women's, but in many other respects, women's health is worse than men's. And I think we have to avoid thinking about this as a binary issue, as if some kind of binary choice has to be made. What we need to do, I think, is to develop gender responsive health systems that benefit everybody, whatever their gender. And I think we saw this very clearly during the COVID pandemic, when it was at its worst. We clearly needed, but we did not achieve, actions which addressed, on the one hand, men's much higher mortality levels and their susceptibility to more serious COVID disease, but also the massive social and economic consequences for women, as well as the consequences of long COVID, which women are much more likely to suffer from than men. But what I'd like to do is to give one example of how a gender-responsive healthcare system could benefit men. And the high suicide rates, the staggeringly high male suicide rates, have already been mentioned. But we are very poor, we're still very poor at addressing men's mental health. Men clearly underreport problems like depression and anxiety because of the way men are socialized. There's a huge amount of stigma about acknowledging and reporting mental health problems. But those problems are also underdiagnosed by healthcare professionals. And we now understand that men may present differently. They may present with different symptoms of conditions like depression and anxiety than women. And healthcare professionals need to be trained to understand these differences so they can diagnose men better and then refer them on to appropriate services with practitioners who also understand men and masculinity and how to work effectively with men. I think we also need to take a look at how we provide primary care services. Clearly, we need to provide primary care services that are more accessible to everybody, but there's a particular challenge for men because, again, because of their socialized reluctance to use services, and also the nature of many men's work, which can make it much harder in practical terms to attend. So I think we need to look at, in much more detail, we haven't done this yet, we need to look at how men can be supported and enabled to access primary care better and to look at solutions that can be mainstreamed. And one obvious area is looking at how we can use new technologies to improve access, and that's beginning to happen. But it's also about basic things like opening hours and the way people can make appointments to see their GP. So if I had to outline some key strategies for promoting gender-responsive health systems, I think what we need to do is to ensure that we have gender in all health policies, not only in terms of overarching policies on men's health and women's health, but also that gender is mainstreamed into cancer policy, cardiovascular policy, mental health policy, and so on. And then, as I also said, we need to look at training for health professionals in gender and health. There's very little training, pre-qualification and post-qualification in gender and health. And I think if we were able to train our healthcare professionals to understand gender differences and how to respond to the needs of all genders, we'd have much more effective gender responsive health systems. So I'll stop there. Thank you.
Thank you very much, Peter. And I think the point that you made about mainstreaming gender in all health, it reminds me of the health in all policies agenda that we've heard so much around the movement towards universal health coverage. But I think if we have as our catchline gender in all health policies, that's a natural consequence and important step forwards. And thank you also for highlighting the importance of focusing on all genders when we talk about gender equality. We are coming close to the end of our time, but I do want to ask each of the panelists for a concluding remark on a particular question. And because we're close on time. I'm going to ask them for one word. So here's the question. Get ready. What is the one most important thing we can do to strengthen support amongst diverse stakeholders for gender responsive health systems for UHC? I had a few words. You get one word. So let's start at the beginning. So Wilhelmina Jala, Dr. Jala, you're first. What's your one word?
I would say disaggregate data.
Disaggregated data will allow you two words, but that's very important. Disaggregated data. Excellent answer. Okay, who's next? Yvette. Yvette Ouedraogo.
Yes, Ouedraogo. Budgétisation sensible au genre.
Okay, that was a few words, but we let that too. Can we repeat the English translation? Sensitivity to people. Thank you for reminding us that UHC has to be people-centered, people at the center. Very important. Okay, Anne Coates.
Evidence on what works, not just the problem.
Very good. I had some audio problems, but I'm sure you all heard that. Thank you, Anne Coates. And let's have Peter Baker.
Not just the science, people's personal stories, lived experience.
Personal stories. So a little bit like Yvette's answer, this is a personal thing. Terrific. Well, I'm sure you all agree, a really terrific set of panelists. We do have a question in the chat, which is an important one from the audience about how we analyze gender mainstreaming in universal health coverage. What are the tools that we can use? What are the models we can use? I'm sure that's something that Women in Global Health would like to respond to. I know we're out of time today, but please can we take note of that and take a note of the question, and perhaps we can respond to that by email. But thank you for the important question. I do want to hand over for some important concluding remarks, however. I want to hand over to Ms. Kanisha Arora, who is a PMNCH youth leader, to deliver those remarks. Ms. Arora is a representative of youth on the United Nations SDG 4 High-Level Steering Committee. Globally, she serves as UNESCO's elected youth representative, where she spearheads a group of 100 young leaders leading the youth movement towards transforming education. Kanisha's non-profit, the Hope Sisters, focuses on uplifting the well-being of underprivileged children in rural and sheltered communities. Already a huge legacy and so many years ahead. Kanisha, over to you to conclude this discussion today.
Thank you so much, Dr. Coonan, for that warm welcome. It is clear from our conversation that these disparities in, gender health systems is not merely a statistical anomaly. It is a stark reflection of the experiences of millions around the world. From our conversation today, I noticed that there are three main gaps that currently lie that are preventing us from having gender responsive systems. First, we talked about the gender gap in healthcare research. For too long, women and adolescent girls have been underrepresented in clinical studies. And this is not only a void in our knowledge, but this is what leads to a void in understanding the unique health challenges of different women and adolescent girls. So this exclusion really does have profound implications. Women and adolescent girls are subjected to care, which is based on data that's not always reflective of their physiology. And so this is not just a gap in women's health, it is actually a violation to the safety of women and adolescent girls everywhere. The second key message that was highlighted today is about the differential care that's experienced by women in healthcare systems. Whether it's from diagnosis to treatment, women are often encountering a healthcare system that is not yet equipped to address their specific medical needs. And this result is a big disparity in our health outcomes, where being female can sometimes mean receiving a lesser standard of care, not due to a malice, but because of a systemic oversight that we need to consciously overcome. And so this consequence is quite severe. It is endangering not only the health of women, but also their lives. The third biggest message is that the gender gap is not uniform. It is wider for some genders and for some from different socioeconomic, races, ethnicities, or geographic locations as well. And so we need to make sure that someone's zip code or income doesn't dictate their quality of healthcare, because this gap of equity not only divides our health systems, but our societies as well. And so, how do we bridge these gaps? Well, we must start by recognizing that a woman or adolescent girl's health extends far beyond her reproductive capabilities. It is not about whether or not she can effectively reproduce a child, because true gender responsive healthcare systems will encompass the full spectrum of women healthcare needs at all stages of life. And that is very crucial. And so, why is it urgent? Why is it urgent for us to act now? Why today? Why now? It's because the world doesn't pause. It doesn't pause for us to catch up. We see that everywhere gender inequities in healthcare are widening, and these are only getting exacerbated by global crises such as pandemics and economic recessions, and also policy. We see that around the world, there is an overturn of women and girls' sexual reproductive health rights. In the United States, there are already 22 US states that have either banned abortion or heavily restricted this. And this number is only increasing in the restriction to this service. And PMNCH, they conducted a survey to understand, well, what is the impact of the US Supreme Court's decision to overturn Roe v. Wade on safe abortion services. And they found that 1/3 of respondents believe that there is less access to SRHR services, including abortion and post-abortion care. So they also found that 1/4 of respondents perceive negative changes in this domestic funding and international funding for SHR services, including abortion and post-abortion care, but also family planning. They also saw in the survey that more than half of the respondents perceive that this overturning has emboldened the anti-abortion movements in their own countries. But that's just one example. We see in other countries that the effects of climate change is not waiting. The rate of environmental degradation accelerates every single day. And with this, it's bringing a host of new health challenges that are disproportionately affecting the most vulnerable among us, the women and girls. However, there are current climate policies that still lack gender responsive measures. So there's been other studies that show that out of the 119 NDCs, nationally determined contributions, that were submitted between 2020 and August of 2022, only 38 countries directly referenced sexual and reproductive health rights. Let me say that one more time. Out of the 119 nationally determined contributions, only 38 countries directly reference sexual and reproductive health rights. That is a big gap. But looking ahead, we can make a difference. It starts by understanding that there is a huge depth to these healthcare systems. They're interconnected. Healthcare systems is more than just about hospitals and treatments. It's about creating environments that promote overall health and well-being. So we see that the education system, the economy, transportation, judicial systems, they're all interconnected and play a big role in creating gender-responsive healthcare systems. And in fact, we see that this is a big ripple effect. Investing an additional $5 per person a year in health systems and high impact health interventions can show that there's a 74% high burden countries that could yield this social benefits, which is just 9 times greater. So just spending $5 per person per year can show a 9 times greater social benefit in our society. That is a big ROI. I might not be an economist, but I know that that is a great return on investment. So let's start by acting. Let's start by investing just that $5. Each of us have this collective responsibility within our respective systems, within our respective fields, to influence positive health outcomes for everyone. And we can do this. You know, we've seen the data we know that we can each in our own respective systems make a difference because we do hold the power, especially because of how interconnected these healthcare systems are. So let's chart a way forward with unified efforts, ensuring that no one is left behind. And we need to commit today to inclusivity and equity in health because this requires attention, especially to those who are most at risk. It's not just about improving healthcare, but it's about enhancing conditions that allow every individual to achieve their best health before they even get to the healthcare systems. Thank you so much for this conversation today. It is very critical that we all play a role, and I look forward to working hand in hand with everyone to ensure that our healthcare systems are gender responsive.
Thanks so much, Kanisha. Thank you for sounding the alarm. If we look back decades, we've come a long way, but right now we are not going forwards, and it's important to be honest about that. But if the future is in the hands of young leaders like you, I think we're in great shape. So thank you for a stellar conclusion to an excellent panel, terrific keynotes and presentations. Thank you all for your contributions in the chat. Thank you all for your questions. If there are some that are unanswered, I would encourage the team to respond if they can by email to make sure that everyone has their questions answered. Thank you all for joining. Please enjoy the rest of the time in New York. Those of you who are there, thank you for joining online, wherever in the world. Have a wonderful day, afternoon, evening. Good night, good morning.